Hello, my name is Brwyn Downing, and I'm an attorney with the Senior Citizens Law Office based in Albuquerque, New Mexico. I will be interviewing Dr. Nancy Guinn regarding end-of-life decisions under New Mexico's Uniform Healthcare Decisions Act. Before I ask Dr. Guinn some questions, I want to refer viewers to the Senior Citizens Law Office's companion video that describes New Mexico's durable power of attorney for healthcare and suggest that viewers watch that video as well. The focus of our conversation will be decisions about medical intervention when a person is at the end of life. This could be due to a number of reasons, such as a terminal illness, advanced dementia, or the failure to recover from a severe stroke or heart attack, or perhaps from a critical accident or injury. But more simply, if the medical opinion is that a person is at the end of life, does the person want to opt for intense medical interventions in the hopes of living slightly longer? Specifically, we will be discussing what it means to choose artificial nutrition and/or hydration, even when a person chooses not to prolong his or her life. This may also be a decision made earlier in the lives of those who have a medical condition that is likely to cause problems with swallowing very late in the disease. An example of this would be dementia or Parkinson's disease. It is very important that a person choose a healthcare agent, a decision maker, and provide instructions well before a serious illness or accident, and discuss one's values and end-of-life wishes with one's healthcare agent, medical providers, family, and friends. And with that, I'd like to welcome Dr. Guinn, and thank you, Doctor, for being here today. Dr. Nancy Guinn is a hospice and palliative medicine specialist in Albuquerque, New Mexico, and is currently the medical director of Presbyterian's Home and Transition Services. Dr. Guinn, can you give some examples of patients you have seen who are at the end of life, albeit from terminal illness, severe stroke or heart attack, critical accident or injury?
In my career, I have taken care of many people who are near the end of life, from all of the things you listed, as well as dementia, for example, which is another common disease that we take care of patients with. And I will say that in the last weeks and days of life, people often look remarkably the same and pass in a similar way. The body slows down, the mind slows down, people are often sleepy, they may sleep and wake. The heart rate will change, breathing will change. All of those things stop, including interest, frankly, in eating or drinking most of the time. And people just fade away, most commonly, when I take care of them, for instance, in our hospice house. That is the picture that we see in most situations.
What does choosing to prolong life mean in those types of situations?
So choosing to prolong life means a lot of different things. We tend to think that we have the ability to make that choice and that medical technology will keep us alive. However, in the end, death will come and the body will pass. So an intervention to prolong life can be a machine that helps you breathe, a shock to restart the heart after the heart has actually stopped. It can be tubes and it can be fluids. It can be a number of things. Right at the end of life, the most common types of prolonging life are things like life support, like machines, to try to keep someone alive. They will not succeed long term if the disease is terminal, but they can prolong death or prolong a time period where a person is alive, perhaps without being awake. Earlier in diseases, there are other ways we prolong life all the time. Right? When someone has late-stage dementia and loses the ability to swallow, we may decide to suggest a feeding tube. People who have pneumonia at the end of their life, we may try to give them antibiotics to keep them alive a little longer or to rescue them from what's happening. Those are also examples of life prolonging.
What does choosing not to prolong life or stopping life prolonging efforts mean?
It means a decision at some point in your condition or your disease to not pursue a medical treatment that may offer some chance of you living longer. It often it often means that you're opting for something involving care that is supportive in nature, that is focused on relieving the stress and the symptoms of your illness, perhaps in your own home.
Are life-prolonging efforts the same as life support?
It can be. As I mentioned before, life support we all think of as being on machines. That's what people often talk to me about, whether they would want to be on a machine or not. But there are many other ways that we make choices attempting to prolong someone's life. I think it's important to say that there was a study many years ago concerning hospice care, which is a benefit that is offered to people when they have an incurable illness in the last months of life. And they found that people who opted for hospice care actually lived longer than people who did not with a similar condition. So that's why the concept of life prolonging is a little confusing, really. Sometimes opting for treatment very late in an illness that is very aggressive, those treatments have side effects. We may not be choosing something that will actually prolong our lives.
Can you give examples of when a person might choose not to have life-prolonging efforts?
I think it would be great if people chose not to have life-prolonging efforts when they were no longer of value to them. So is another day in the hospital of value to you compared to time at home, or a week in the hospital? Is a week on a machine in a medically induced coma of value? So in other words, when is an intervention going to get you what you might want? I'm thinking specifically of a patient I took care of a number of years ago who was a rancher in his late 80s. He already had some dementia, and now he'd been diagnosed with a lung cancer. So I said to him, what is a day that you like? And he and the whole family talked about how he liked to sit on the bench in the back of the house and look at the animals, and he liked to drive around the ranch with his son and check on everything and check on, he'd be in the backyard with the grandkids and the pets, and that was of value to him. We could have initiated treatment for the lung cancer. It might have prolonged his life, but it would not have prolonged his days on the ranch in the place he wanted to be, because he would have been spending an enormous amount of time driving back and forth to Albuquerque to get his treatments, and each one of those days would have been a day he didn't have where he wanted to be. So that's an example of a choice you make based on your quality of life and what you value.
In New Mexico, a person who makes a choice in their advanced healthcare directive not to prolong life in the case of a terminal event will still be asked to specify if they opt to have artificial nutrition and/or hydration. What is artificial nutrition?
Artificial nutrition is given through a tube. It can be given through a tube through the nose that's inserted in the hospital and put down in your stomach. That's a temporary measure, but it might last for days or weeks. It could be inserted in a tube in the vein, less frequently, but that's a possibility. And then also the most common way that artificial nutrition is given long-term is there's a small surgical procedure where they actually insert the tube through the abdominal wall into the stomach or the upper intestine, and nutrition is pushed through that tube into the stomach and intestine.
Can there be complications from the administration of artificial nutrition?
Yes. It is of great benefit to people for whom it is a benefit. I know that sounds very contradictory, but what I mean is if someone is born without the ability to successfully swallow food or has an intestine that doesn't work well, we use artificial nutrition very appropriately to allow them to grow, to nurture, to have a life, to do really important things. In someone with late-stage dementia, in fact, end-stage dementia, because you lose the ability to swallow long after you've lost the ability to recognize your family or friends, and long after you're able to move on your own without prompting. When you lose the ability to swallow at that point, artificial nutrition is often advised. What they're trying to avoid partly is the fact that people, when they swallow, will aspirate. Studies actually, which will cause an infection in the lungs. Studies actually show that tube feeding in the stomach still has the same side effect of aspiration. So it's not accomplishing what we're looking for. In addition, artificial nutrition has a myriad of other potential side effects. So I'm a huge advocate of using it when it's appropriate to prolong a meaningful life. What I would want to avoid personally is having it used on myself or loved ones when the only result was to prolong a period of life which was not of value.
What is artificial hydration?
Artificial hydration is fluid through a vein, through a tube into the vein. That is always a temporary measure. And by that what I mean, we all use the phrase nowadays, now that we've all seen it on TV, of IV fluids. Well, we'll use IV fluids. So when you're no longer able to swallow liquids, or you're temporarily not able to function well enough to swallow, like after an automobile accident, we all know that one of the things you do is start fluids. The trick is that we've also gotten accustomed to the idea that if someone is no longer swallowing and has lost all sense of hunger or thirst, that we still must give them fluids. We're human beings. We live to nurture. We feed people. We want everyone to eat and drink and not feel thirst. However, fluids through the vein are appropriate only in circumstances in which, again, you will recover and will be able to have a meaningful life. At the end of life, what fluids tend to do is cause more harm than good, not just by prolonging someone's suffering, but also by actually, when the body breaks down, fluids no longer even stay where they're supposed to. So fluids through the vein in the last days of life may end up as fluids in the lung or fluids under the skin, and they may cause more suffering than benefit. So it's always critical when you think about fluids to understand when they would be given.
What does pain and symptom control mean?
It means assessing someone both through nonverbal as well as verbal signs and really trying to understand what's troubling them, what is causing their suffering from their illness, and addressing it in the best way possible. We always think about pain, and we think about heading towards medications for pain, and those are important to be able to administer. There's also medications for anxiousness and restlessness and all the things that can happen to us very late in the dying process. There are things that are not pills that are also really of value to people, right? Just touch and support and conversation with people who are skilled at that conversation, or with family and friends. That's why all palliative care teams and hospice teams are interdisciplinary, because the value of an entire team, including the skills of a social worker or a chaplain or a nurse, are there to assist someone in managing pain and symptom control.
Why would a patient refuse pain and symptom control?
The most common reason I see people refusing pain and symptom control is due to fear of the medications. And currently, there is such a focus on opiates as being a problem that it's actually hard for people to be able to use them very appropriately for pain and symptoms late in life. So that's the most common reason I see people refusing pain and symptom control. I think the other reason is an urge to be in control, right? We all like being in control, so it's that sense of I'm going to be out of control if I use medicines. And in that case, it's just very important to work with people and make sure that they are able to control their own medicines and decide what works for them and not. And the last thing is a fear of not being alert. And in the last days or weeks of life, often we work with patients and families, and everyone gets, the patient gets to decide what balance they want between managing symptoms and the alertness that they crave.
Does Medicare pay doctors to consult with patients about their end-of-life decisions?
It does. There's actually a special billing code now that was created by Medicare for the purpose of encouraging advanced care planning conversations.
Thank you, Dr. Guinn, for your very informative answers to my questions.
You're welcome. Thank you.